Welcome to the Deep Dive, the show where we arm ourselves with cutting-edge sources and distill complex topics into the essential insights you need to truly master a subject. Today we're plunging into a condition that affects nearly 1 million people annually in the United States, yet is often dismissed as just a bulge, hernias. But as we're about to discover, hernias are far more than a simple protrusion. They are a complex, chronic disease process with profound implications for daily life and long-term health. Our mission today is to extract the most important nuggets of knowledge from expert surgical texts, going beyond surface-level facts to truly understand the why and how behind them, equipping you with a foundational understanding akin to an elite professional in this field.
That's right. Our goal is to empower you to master this information. We're going to set the stage by moving from fundamental definitions and core concepts to the intricate anatomical details that dictate how and why hernias occur. We'll explore the varied philosophies behind their treatment, from watchful waiting to cutting-edge surgical innovations, including robotic approaches, and the evolving holistic concept of abdominal core health. By appreciating these nuances, you'll gain a dynamic understanding of a field that is constantly adapting and improving, giving you a comprehensive view of how we approach this prevalent condition.
So let's unpack this right from the very beginning. What exactly is a hernia? The term itself is derived from the Latin word for rupture. At its simplest, a hernia is an abnormal protrusion of an organ or tissue through a defect in its surrounding walls. Think of it like a weak spot in an old tire, allowing the inner tube to bulge out where the tire itself has lost its integrity.
Exactly. And while a hernia can technically occur at various sites throughout the body, our sources emphasize that these defects most commonly involve the abdominal wall, with the groin area being particularly prevalent. The anatomical reason for this commonality is quite specific. Abdominal wall hernias occur only at sites where the strong, connective tissue layers, what surgeons call aponeurosis and fascia, are not adequately covered by robust striated muscle. These are natural weak points in the body's structural envelope, including regions like the inguinal or groin, femoral, umbilical areas, the linea alba, and significantly sites of prior surgical incisions.
Okay, so a weak spot, a protrusion. What are the key anatomical features we need to understand when we're talking about a hernia? Our sources highlight two main components: the neck, or orifice, and the hernia sac.
Right. The neck or orifice is essentially the innermost part of the defect, the deepest point where the protrusion begins, almost like the narrow opening of a bottle. From this neck, the hernia sac, which is basically lined by peritoneum, that smooth membrane lining the abdominal cavity, protrudes, holding the herniated contents.
And it's interesting, the sources note there isn't always a consistent relationship between the size of the initial defect itself and the actual size of the hernia sac. A very small opening, for example, might allow for a surprisingly large sac to balloon out, and vice versa.
Precisely. It's not always intuitive. Hashtag categorization by reducibility and complication. When clinicians describe hernias, they often categorize them based on two critical factors: their reducibility and the presence of complications. A hernia is described as reducible when its contents can be manually or spontaneously pushed back or replaced within the surrounding musculature, essentially putting the bulge back inside.
Okay.
Conversely, it's considered irreducible or incarcerated when those contents cannot be replaced. Think of it like a knot that won't untie.
Here's where it gets really interesting and potentially quite serious. An incarcerated hernia can quickly escalate to a strangulated hernia. This is a grave, potentially fatal complication where the blood supply to the hernia's contents has become compromised.
Exactly. And strangulation tends to occur more often in larger hernias that paradoxically have very small or tight openings or necks. In this scenario, that small neck acts like a tourniquet, cutting off arterial blood flow, venous drainage, or both, to the organs or tissues trapped within the hernia sac.
And to make matters worse, adhesions, those bands of scar tissue, can form between the hernia's contents and the sac lining.
Yes, and they can act as a tethering point, further entrapping the contents and predisposing the patient to intestinal obstruction and ultimately strangulation. It becomes a surgical emergency.
Right.
And then we have a particularly unusual form of strangulation known as a Richter hernia. What's fascinating here is that only a small portion of the anticenteric wall of the intestine, that's the side opposite the blood supply attachment, gets trapped. The critical distinction for a Richter hernia is that strangulation can occur without intestinal obstruction.
Wow. So someone could have dying bowel without the typical signs of a blockage?
Precisely.
Yeah.
Which makes diagnosis very challenging and can delay critical intervention. Hashtag hernia types by protrusion and location.
Moving on to different ways hernias can present, we broadly categorize them based on how they protrude and where they're located. First, we have an external hernia, which is one that protrudes through all layers of the abdominal wall, making it visible or palpable from the outside.
In contrast, an internal hernia is a protrusion of the intestine through a defect within the peritoneal cavity itself, meaning it stays inside the abdominal space and isn't externally visible.
Okay.
And falling somewhere in between these two is the interparietal hernia. This occurs when the hernia sac is contained within a musculo-aponeurotic layer of the abdominal wall. So it's not fully external nor purely internal. It's kind of tucked away between muscle and fascia layers, potentially making it harder to spot.
Broadly speaking, though, our sources tell us that most abdominal wall hernias can be simply separated into two major categories for discussion: inguinal hernias, primarily in the groin, and ventral hernias, those on the front of the abdomen. We'll be diving deep into each of these categories individually, starting with that very modern and holistic approach to abdominal wall care. Now, this is a really interesting and important shift in perspective. Historically, we might have just talked about abdominal wall surgery, but increasingly there's a modern rebranding of abdominal wall care that encompasses so much more. It's now referred to as abdominal core health.
Exactly. And this concept goes beyond just fixing a hole. It focuses on the broad scope of stability, function, and overall quality of life for the patient. It's about the whole system working together.
It sounds much more comprehensive.
It is. This rebranding is actually quite significant, reflecting a deeper understanding of the body's mechanics. The abdominal core is precisely defined as the circumferential soft tissues that collectively provide stability and function. This includes the diaphragm superiorly, the pelvic floor inferiorly, and the abdominal wall and flank anterolaterally.
So it's the whole barrel, basically.
Right. And it's crucial to note that this definition explicitly excludes the abdominopelvic viscera themselves, focusing solely on the structural integrity of the surrounding soft tissues, the container, rather than contents.
So if we're talking about maintaining this abdominal core health, it's clearly not just about surgery. Our sources lay out a diverse range of approaches. This can include non-invasive options like exercise and physical therapy to strengthen the surrounding musculature.
And it extends to medical therapies, which might involve the use of compression garments or even a traditional truss, a device worn to hold the hernia in.
Interestingly, it also incorporates alternative therapies like acupuncture or yoga, recognizing their potential role in overall well-being. And of course, surgical intervention plays a critical role when necessary.
Sure, but it also emphasizes preventive measures, like hernia prophylaxis, to prevent the condition from developing in the first place or recurring.
What's fascinating here is the significance of this rebranding. It's not just a new buzzword, is it?
Not at all. It's truly reflective of the comprehensive care actually provided to patients. By framing it this way, it opens new avenues for both clinical care and much-needed research, moving beyond simply treating a defect to optimizing a critical bodily system. This holistic view helps us determine optimal treatments that consider the patient's entire functional core and identify more effective methods of prevention, rather than just focusing on repair after the fact. It reinforces that hernia management isn't just a surgical procedure. It is an integral component of maintaining abdominal core health for a patient's entire lifetime.
Let's shift our focus now to the most common type of hernia, the inguinal hernia, which is predominantly found in the groin region. When we classify these, the primary distinction is between a direct or an indirect inguinal hernia.
Right, and the difference between direct and indirect hernias lies in their anatomical paths. In an indirect inguinal hernia, the sac passes obliquely from the internal inguinal ring, that's a deep opening, toward the more superficial external inguinal ring, often eventually descending into the scrotum in men. Think of it like a winding path.
Okay.
Conversely, a direct inguinal hernia protrudes directly outward and forward, medial to a key set of blood vessels called the inferior epigastric vessels. This is more like a straight push through a weakened spot in the wall.
You know, it's interesting. Our sources mention that as indirect hernias get larger, it can actually become quite difficult to tell the difference between an indirect and a direct inguinal hernia just by physical examination.
That's true. It can be tricky.
But practically speaking, this distinction often turns out to be of little importance because the operative repair for both types of hernias is quite similar in modern practice, making the precise classification less critical in guiding the immediate surgical approach.
Correct. The approach often covers both possibilities. And sometimes you encounter a fascinating hybrid. A pantaloon-type hernia is where there is actually a combination of both an indirect and a direct hernia component, essentially creating a double-barreled hernia through adjacent weak points in the groin. Hashtag incidence and demographics.
Now, for some staggering statistics that really drive home how common these are, it's estimated that about 5% of the general population will develop an abdominal wall hernia at some point.
Wow, 5%.
Yeah. And of all these hernias, a massive 75% occur specifically in the inguinal region.
75% in the groin.
Within that 75%, about 2/3 of inguinal hernias are indirect, with the remaining third being direct. Femoral hernias, which are also in the groin region but occur through a different pathway, represent only about 3% of all groin hernias.
When we look at demographics, the picture becomes even clearer. Men are a striking 25 times more likely to experience a groin hernia than women. And while an indirect inguinal hernia is the most common type regardless of gender, in men, indirect hernias outnumber direct hernias at a ratio of 2 to 1.
Interesting. What about women?
Well, for women, indirect hernias are still by far the most common type of hernia they experience, despite a higher female-to-male ratio for other types like femoral hernias, which are about 10 to 1 women over men, and umbilical hernias, about 2 to 1. But even with these specific ratios, inguinal hernias still remain the most common overall hernia in women. Femoral hernias in particular are quite rare in men.
And the text mentions that about 10% of women and a full 50% of men who have a femoral hernia will also have or eventually develop an associated inguinal hernia.
Exactly, there's often an association there.
There's also an interesting right-sided predominance for both indirect inguinal and femoral hernias. Our source attributes the right-sided prevalence of indirect hernias to a slight developmental delay in the descent of the right testis during fetal development.
And for femoral hernias, the right-sided predominance is thought to be caused by the tampating effect of the sigmoid colon on the left femoral canal, essentially protecting it somewhat.
Fascinating.
And as we age, the prevalence of hernias generally increases, particularly for inguinal, umbilical, and femoral types. With increasing age, there's also a higher likelihood of experiencing a serious complication like strangulation, and thus a greater need for hospitalization.
Right, strangulation. We keep coming back to that.
It's the most serious complication. While it occurs in a relatively small percentage, only 1% to 3% of groin hernias, it is more common at the extremes of life, meaning in very young children or the elderly. Most strangulated hernias are indirect inguinal hernias, but it is absolutely critical to highlight that femoral hernias have the highest rate of strangulation of all hernias, ranging from 15% to 20%.
15 to 20%, that's huge compared to 1-3%.
It really is. Because of this significantly higher risk, the recommendation is quite clear. All femoral hernias should be repaired at the time of discovery without delay. No watchful waiting there.
This brings us to a crucial section, the anatomy of the groin. For any surgeon, and certainly for us to understand this topic like an elite professional, a comprehensive understanding of this complex region is absolutely critical. It's not just about knowing names, it's about understanding the precise relationships between muscles, connective tissues, nerves, and blood vessels.
Absolutely. This detailed knowledge is what allows surgeons to choose the proper repair options, achieve the lowest possible incidence of recurrence, and, perhaps most importantly, avoid devastating complications like chronic pain or organ damage. We really need to look at these anatomical considerations from both an anterior or front approach and a posterior or back approach, because both are utilized in different surgical situations.
Okay, let's get into the layers.
Right. So immediately beneath the skin are several superficial blood vessels that need to be managed. Deeper, the most superficial muscle layer, the external oblique muscle, forms a strong, flat tendon or aponeurosis. Its lowest border forms the inguinal ligament or Poupart's ligament, a crucial landmark running from the hip bone, the anterior superior iliac spine or ASIS to the pubic bone, the pubic tubercle.
Okay, that ligament is key.
It is. Medially, this ligament flares out to form the lacunar ligament, which helps define the femoral space. The external inguinal ring is an opening in this external oblique layer where a hernia might emerge superficially.
Got it. What's next deeper?
Beneath the external oblique lies the internal oblique muscle. It forms part of the roof of the inguinal canal and gives rise to the cremaster muscle, which surrounds the spermatic cord in men. Minimal disruption of this muscle is important to reduce chronic groin pain later on.
Makes sense. And the deepest layer?
The deepest layer is the transversus abdominis muscle and its underlying transversalis fascia. These are critical for preventing and treating hernias. The iliopubic tract is a particularly important band of connective tissue in this deep layer. It runs parallel to the inguinal ligament but is located deeper, and it crosses over important femoral blood vessels.
So that iliopubic tract is a major landmark.
A vital boundary, especially in laparoscopic repair. Placing sutures or tacks below it risks injuring major nerves like the femoral, lateral femoral cutaneous, and genitofemoral nerves. Big trouble.
Okay, noted.
Behind the iliopubic tract and forming part of the femoral canal is the pectineal Cooper ligament. This is a strong, fibrous band along the pubic bone, often used as a robust anchoring point for mesh in hernia repairs. There's a branch of the obturator artery that crosses it in about 75% of patients, posing a risk of bleeding if injured during fixation.
Good to know. What about the canal itself?
Right, the inguinal canal itself is a short passageway, about 4 centimeters where hernias occur. It's essentially a tunnel with a defined roof, floor, and front and back walls. In men, it carries the spermatic cord containing testicular vessels, the vas deferens, and nerves. In women, it contains the round ligament.
And Hasselbalch's triangle?
Ah, yes. A key area within the inguinal canal is the Hasselbalch triangle. It's defined by the inferior epigastric vessels superolaterally, the rectus sheath medially, and the inguinal or pectineal ligament inferiorly. This triangle is clinically significant because direct hernias push straight out through this triangle's weakened floor, whereas indirect hernias enter the inguinal canal lateral to it, through the internal ring. Understanding this distinction helps surgeons pinpoint the hernia's origin.
Okay, so direct is in the triangle, indirect is lateral to it.
Exactly. Though large indirect hernias can eventually weaken the floor too. And finally, in the groin, there are several important nerves that surgeons meticulously identify and avoid to prevent chronic pain. The iliohypogastric and ilioinguinal nerves provide sensation to the groin and upper thigh. The genital branch of the genitofemoral nerve supplies the cremaster muscle and sensation to the scrotum or labia. These nerves are carefully preserved, as their injury is a significant cause of postoperative pain.
So, with that incredible anatomical map in mind, let's move to how these hernias are diagnosed. The main diagnostic finding for most groin hernias is quite straightforward: a visible or palpable bulge in the inguinal region. While most patients experience some associated pain or vague discomfort in the area, it's worth noting that about 1/3 of patients might have no symptoms at all. Generally, groin hernias aren't intensely painful unless complications like incarceration or strangulation have occurred.
Right. The physical examination for a groin hernia is quite meticulous. It begins with examining the patient in both lying down and standing positions, carefully looking for any asymmetry, bulges, or masses. To help identify a subtle hernia, the patient is often asked to cough or perform a Valsalva maneuver, which increases intra-abdominal pressure and can make a protrusion more evident.
Like bearing down.
Exactly. A fingertip examination over the inguinal canal and into the external inguinal ring helps detect smaller hernias. A bulge that moves from lateral to medial within the inguinal canal strongly suggests an indirect hernia. If, however, the bulge progresses from deep to superficial, pushing directly through the inguinal floor, a direct hernia is suspected.
And as you said, that distinction isn't always critical for the repair plan.
Correct. Finally, a bulge identified below the inguinal ligament is highly consistent with a femoral hernia. If a hernia is suspected but undetectable, repeat examinations or imaging like ultrasound or even laparoscopy can be invaluable. #tag classification systems for groin hernias. There are numerous classification systems that have been developed for groin hernias, each with its own merits and complexities. These systems aim to provide a common language among medical professionals for better communication and to allow for appropriate comparisons of different therapeutic options in research.
One system that is described as simple and widely used is the Nyhus classification, which categorizes hernias into 4 main types based on the internal ring and posterior wall defects. Another, the European Hernia Society groin hernia classification, primarily characterizes hernias as femoral, or as medial or lateral to the epigastric vessels, further detailing them by the size of the orifice or defect.
However, our source material highlights that these classifications are often incomplete and can be contentious, leading to ongoing debate among experts. Ultimately, most surgeons continue to describe hernias using a more practical approach, by their general type, their precise location, and the volume of the hernia sac. That tends to be more useful day to day.
Makes sense. Practicality often wins out. #tag treatment of inguinal hernias. #tag non-operative management. When it comes to treating inguinal hernias, the general recommendation from most surgeons is to operate upon discovery of a symptomatic inguinal hernia. This is largely because the natural history of a groin hernia is one of progressive enlargement and weakening, carrying a small but significant potential for incarceration and strangulation.
Right. But for patients with minimal symptoms, the clinical decision often involves a delicate balance between the inherent risks of hernia-related complications and the potential for short and long-term complications from surgery itself.
So it's not always straightforward.
Exactly. This is where the concept of watchful waiting comes into play, primarily for asymptomatic or minimally symptomatic men. A landmark prospective randomized trial, the Fitzgibbon study, looked at over 700 men. At a 2-year follow-up, there were no deaths directly attributed to the study, and the risk for hernia incarceration in the watchful waiting group was remarkably low, about 0.3%.
Very low.
Yes. While many patients eventually crossed over to the surgical group, most often due to pain developing, the study found that patients who delayed surgery did not experience increased surgical site infections or higher recurrence rates compared to those who underwent immediate repair. The conclusive evidence from these studies is that watchful waiting is a safe strategy for older men with asymptomatic or minimally symptomatic inguinal hernias.
Okay, but it's extremely important to emphasize the crucial exclusions for this watchful waiting strategy. The results from these studies should not be applied to women, as women were not included in these trials.
Absolutely critical point. No data for women there.
Furthermore, this approach is not recommended for patients with femoral hernias, which, as we discussed, carry that significantly greater risk of strangulation compared to inguinal hernias.
Correct. Femoral hernias need prompt repair. For patients who do elect for non-operative management of an inguinal hernia, a truss, a special belt or garment, can occasionally provide symptomatic improvement, but is not a definitive solution and can have its own complications, like skin irritation or even testicular atrophy in rare cases.
Now let's talk about the surgical gold standard. Anterior repairs, performed via an incision on the front of the abdomen, remain the most common operative approach for inguinal hernias. The fundamental principle governing modern hernia repair is the tension-free approach. Older tissue-based repairs, which involved pulling native tissue together under tension, are rarely indicated today because they led to high recurrence rates.
That's the key shift, avoiding tension. The main exceptions where a mesh prosthesis might be contraindicated and a tissue repair necessary are in patients with simultaneous contamination, such as a wound infection or a concomitant bowel resection, where introducing a foreign body like mesh could increase infection risk significantly.
Okay, so how does the open repair work?
In open repair, the surgeon carefully dissects through layers of tissue to expose the hernia. A critical step is the identification and careful avoidance or mobilization of key nerves in the groin, the ilioinguinal, iliohypogastric, genital branch of genitofemoral, to prevent their transection or entrapment, which can lead to chronic pain. The hernia sac holding the protruding contents is then managed. For an indirect hernia, the sac is carefully separated from the spermatic cord structures and either pushed back, ligated, or excised. For a direct hernia, the weakened floor of the inguinal canal is often opened and then reinforced.
A particular challenge here is a sliding hernia, where a portion of the hernia sac itself is composed of part of an organ, most commonly the colon or the urinary bladder.
Yes, that's a tricky situation. The primary danger here is that the surgeon might not recognize this visceral component of the hernia sac before inadvertently injuring the bowel or bladder during dissection or ligation. Careful recognition and gentle reduction of the organ are paramount before the hernia is repaired using standard techniques, often involving careful suturing of the peritoneum over the exposed organ. As you noted, tissue repairs are largely historical for primary hernia management due to high recurrence rates. However, they remain profoundly useful in specific situations, particularly when mesh is contraindicated due to infection or compromised tissue.
So they still have a place.
Definitely. These techniques essentially involve using the patient's own tissues to reconstruct the weakened area. The iliopubic tract repair, Schuldeis repair, the Sini repair, and Cooper ligament, McVeigh repair, are examples. The McVeigh repair, for instance, is still valuable for strangulated femoral hernias because it obliterates the femoral space without using mesh, making it safe in contaminated scenarios. These repairs typically involve suturing different layers of the abdominal wall together, often requiring a relaxing incision in a nearby strong layer, like the rectus sheath, to reduce tension on the repair, which helps to lower pain and recurrence.
Moving from historical methods to current standards, the tension-free repair has become the absolute dominant method for inguinal hernia repair. The core principle, popularized by surgeons like Lichtenstein, is that tension in a repair is the principal cause of recurrence. Therefore, the modern approach involves using a synthetic mesh prosthesis to simply bridge the defect, rather than pulling tissues together under strain.
Exactly. This fundamentally changes the mechanics of repair. The Liechtenstein repair is a foundational tension-free method. It involves fashioning a piece of non-absorbable prosthetic mesh, typically polypropylene, to fit the contours of the inguinal canal. The mesh is carefully sutured to the strong connective tissue edges, like the inguinal ligament shelf and the conjoined tendon area, ensuring it overlaps the defect generously without creating tension. Crucial steps involve slitting the mesh to accommodate this spermatic cord and ensuring that nerves are protected from entrapment.
Are there other tension-free methods?
Yes, several variations exist. The plug and patch repair, where a cone-shaped mesh plug is inserted into the hernia defect, especially the internal ring for indirect hernias, and often covered with an overlying mesh patch. And the sandwich technique, which uses multiple mesh components layered together. These methods have really revolutionized hernia repair by focusing on reinforcement rather than reconstruction under tension, leading to much lower recurrence rates.
Beyond open anterior repairs, we have laparoscopic inguinal hernia repair, which represents another method of tension-free mesh repair. But critically, it's based on a perperitoneal approach, meaning the mesh is placed from the inside behind the abdominal wall layers.
Right, it's a fundamentally different viewpoint.
Proponents of this approach highlight several advantages. Potentially a quicker patient recovery, less post-operative pain, superior visualization of the intricate anatomy from the inside, and its versatility in fixing all types of inguinal hernia defects simultaneously. However, it also draws criticism for potentially longer operative times, increased technical challenges for the surgeon, and a small but significant risk of visceral or vascular injury, maybe around 0.3%.
That's the trade-off discussion. The core mechanical advantage of laparoscopic repair is its ability to place a large piece of mesh behind the defect, effectively covering the entire myopectoneal orifice, that deep anatomical weak spot where all groin hernias can emerge. By placing the mesh in this preperitoneal position, it utilizes the natural forces of the abdominal wall Pascal's principle, essentially to disperse intra-abdominal pressure over a larger area, thereby supporting the mesh securely in place.
So the pressure actually helps hold it.
In theory, yes. There are two main laparoscopic approaches. The totally extraperitoneal TAP approach, where the dissection begins directly within the preperitoneal space using balloon dissectors sometimes, and the transabdominal preperitoneal PABP approach, where the surgeon first enters the main abdominal cavity and then creates a peritoneal flap to access the preperitoneal space.
TAP versus TAPP. Pros and cons.
Well, TAPP potentially avoids intraperitoneal complications, but has a smaller working space and can be tricky if there's a large peritoneal tear. TAPP offers a larger workspace, maybe easier for learning, and essential to know if a TEP needs conversion. For surgeons, the critical steps in both involve meticulously identifying landmarks like the inferior epigastric vessels, Cooper ligament, and especially nerves such as the lateral, femoral, cutaneous, and genitofemoral nerves, which lie deep to the iliopubic tract. That's the danger zone for tacking. Mesh is then unfurled to cover all potential hernia sites, direct, indirect femoral, and secured, often with tacks or staples, carefully avoiding those nerves and vessels in the triangle of doom near the iliac vessels.
Building on laparoscopic techniques, we now see the advent of robotic repair. Specifically, the TAPP technique can also be performed robotically. The setup, the dissection steps, the mesh positioning, and even the reported outcomes are quite similar to traditional laparoscopy, aren't they?
They are very similar in principle. The key advantages of the robotic approach lie in its technological enhancements. Firstly, it offers three-dimensional optics, providing the surgeon with a far more immersive and accurate view of the anatomy compared to the two-dimensional view of conventional laparoscopy.
Better depth perception.
Exactly. Secondly, the wristed instrumentation of robotic arms provides significantly improved mobility and dexterity, which is a considerable benefit for intricate dissection and critically for suturing. This latter point is a notable advantage as it allows for the simplicity of fixating the mesh to the abdominal wall using sutures rather than a penetrating mechanical fixation device like tacks or staples, which may intuitively confer a slight pain advantage, though that's still being studied closely.
So potentially less post-op pain from fixation.
That's the hope, or at least one potential benefit being explored, especially compared to tacks. Its overall utility versus open for primary unilateral hernias is still an area of active research and debate regarding cost effectiveness and outcomes. #tag complications and results of inguinal hernia repair. #tag data sources and limitations. When we talk about the results and complications of hernia repair, the best and most reliable information typically comes from large prospective randomized trials, comprehensive meta-analyses, and robust national registries like the Danish and Swedish hernia registers, which capture a huge percentage of operations.
However, it's crucial to exercise caution when interpreting the results from these sources. Many studies involve highly selected patient populations, often excluding complex cases like recurrent or very large hernias. Furthermore, some follow-up results are gathered via telephone interviews rather than direct physical examination, which might lead to an underestimation of complications like recurrence.
That's a key limitation. And similarly, national registries, while comprehensive, only collect information on procedures performed, meaning the true incidence of recurrence for patients who don't get another operation could be higher than what is reported. #tag mortality. Thankfully, the mortality rate for all types of inguinal hernia repair is generally very low, and no significant differences have been reported among the various techniques. The mortality risk is primarily elevated in cases involving strangulated hernias, where the compromised blood supply to bowel can lead to severe systemic issues, sepsis, etc. Otherwise, the risk of death is predominantly related to the patient's individual comorbid conditions, heart disease, lung disease, and so on.
It's also interesting to note that the type of anesthesia used, whether general, regional, like spinal, or local, does not appear to affect the recurrence rate of hernias. This is particularly relevant because open repairs can be effectively performed under local anesthesia, which can be a significant advantage for high-risk patients who might not tolerate general anesthesia well.
Right, it broadens the options for sicker patients. #tag hernia recurrence, primary outcome. Hernia recurrence is widely considered the primary outcome assessed in most studies evaluating hernia repair techniques. Overall, across large series, recurrence rates can range from, say, 1.7% up to 10%, depending on the study, technique, and follow-up.
When we look specifically at older tissue repairs, the recurrence rates have historically been quite variable and generally higher than modern methods.
Definitely higher. In stark contrast, tension-free repairs, which utilize prosthetic mesh, consistently demonstrate a significantly lower rate of recurrence. The Danish hernia database, for example, showed Liechtenstein repair had about a quarter of the recurrence rate of non-mesh repairs. Cochrane reviews confirm prosthetic mesh repairs have a 50% to 75% lower risk of recurrence.
So mesh really made a huge difference there. What about Schuldes? That one has a good reputation sometimes.
The Schuldes repair can achieve low recurrence in highly selected patients and specialized centers. But meta-analyses generally show it has higher recurrence than mesh repairs, unless mesh is also used. When comparing different mesh techniques like Liechtenstein, mesh plug, or bilayered devices, large meta-analyses generally find no significant differences in recurrence, chronic groin pain, or other major complications.
When do recurrences usually happen?
About half occur within 3 years for primary repair. Recurrence can continue long-term for non-mesh repairs, but it's less common late after a tension-free mesh repair.
And laparoscopic versus open mesh?
A major European meta-analysis back in 2002 found laparoscopic repair led to quicker return to activity and less persistent pain. Recurrence was lower than open non-mesh, but similar to open mesh repairs. Mesh is the key.
But didn't a big VA trial show higher recurrence with the laparoscopic?
Yes, that's a really important study. The Veterans Administration trial compared Liechtenstein open mesh repair versus laparoscopic TEP. It showed a twofold higher recurrence after laparoscopic, 10% stint, than open, 5%, even for primary hernias. However, for patients who already had a recurrent hernia, the laparoscopic approach actually had fewer re-recurrences, 10%, compared to another open repair, 14%.
Interesting twist. What was the take-home message?
The critical takeaway from the VA study was that laparoscopic repair has a definite learning curve to achieve low recurrence rates. Surgeon experience, and maybe age over 45, were independent predictors of recurrence after laparoscopic repair in that study, underscoring the importance of adequate training and experience.
And TAPP versus TEP?
Cochrane reviews suggest no difference in recurrence between TPP and TEPI. TEPP might have slightly more port site hernias or rare vascular injuries, while TEPI has a slightly higher conversion rate to TPP, or open. #tag other key complications, table 45.1. While we've highlighted recurrence, it's important to understand that the overall complication rate from hernia repair is estimated to be approximately 10%. Many of these are transient, like bruising or temporary swelling, but some are more serious.
Let's break down the big ones. Surgical site infection.
Surgical site infection, SSI rates are relatively low, maybe 1–2% for open, slightly less for laparoscopic. These are generally clean operations. Routine antimicrobial prophylaxis isn't usually needed for low-risk patients, but for higher-risk patients, ASA class 3 plus, or significant underlying disease, a single dose of something like cefazolin is often given. Importantly, mesh placement itself doesn't seem to increase infection risk or necessitate prophylaxis. If mesh does get infected, which is serious, management depends. Superficial infections might just need wound opening. Deep ones involving mesh often require mesh removal, especially with EPTFE mesh. Polypropylene might sometimes be salvaged.
Okay, the one everyone worries about, nerve injury and chronic pain.
Yes, nerve injuries and chronic pain syndromes are unfortunately an infrequent but often under-recognized and debilitating complication. Injury can occur through traction, electrocautery, transection, or entrapment by sutures, staples, or even the mesh itself causing inflammation. The nerves most commonly affected during open repair are the ilioinguinal, genital branch of genitofemoral, and iliohypogastric nerves. During laparoscopic repair, the lateral femoral cutaneous nerve, neuralgia paresthetica, and the genitofemoral nerve are more commonly at risk due to the deeper dissection plane and tack placement. Femoral nerve injury is rare, but possible.
How does it present?
Transient nerve pain or numbness usually resolves in weeks. But persistent neuralgia pain, burning, hyperesthesia lasting more than 3 months can occur in up to 10% of patients after open repair, and in 2–4%, it severely interferes with daily life. It might be reproduced by palpation or specific movements like hip extension. This chronic posterior neuropathy pain has actually replaced recurrence as the primary complication driving patient dissatisfaction and further intervention after open inguinal hernia repair.
How do surgeons prevent it?
Prevention strategies are key. For open repair, meticulous identification and preservation of all 3 major nerves in situ, if possible. Avoiding fixation directly to the pubic tubercle periosteum. Minimal disruption of cremasteric fibers. Using absorbable sutures for mesh fixation supramedially to avoid nerve impingement. Interestingly, studies on routine nerve division haven't consistently showed a reduction in chronic pain, but do cause more sensory disturbance. For laparoscopic repair, operating remotely from the nerves, judicious tack placement, avoiding the triangle of doom and below the iliopubic tract laterally. Intuitively, it might lead to less chronic pain, but the data is still controversial.
And if chronic pain does happen,
managing persistent nerve pain is complex. It often starts with anti-inflammatories, analgesics, and local anesthetic nerve blocks. Specialized centers have programmatic approaches. Operative options exist, like removing problematic mesh or tacks, or even neurectomy, deliberately cutting the nerve. This trades debilitating pain for numbness or paresthesia, which many patients find a welcome trade-off. But it's complex, and more data is needed on long-term outcomes.
what about testicular issues in men?
Ischemic orchitis and testicular atrophy can occur due to blood clot formation in the small veins of the pampiniform plexus in the spermatic cord, or rarely injury to the testicular artery. Symptoms are a swollen, tender testis appearing 2 to 5 days post-op, which can persist for weeks and often leads to testicular shrinkage or atrophy. Orchiectomy, removal of the testis, is very rare. Prevention focuses on avoiding unnecessary dissection within the spermatic cord itself. The risk is higher with dissection of large distal indirect sacs, and particularly higher after operations for recurrent hernias, especially using an anterior approach again. The risk can increase 3 to 4 times with each recurrence repair.
Injury to the vas deferens or bowel?
Injury to vas deferens and viscera, like bowel or bladder, is unusual. Most often occurs in those tricky sliding inguinal hernias where the organ is part of the hernia sac and isn't recognized before being cut or cauterized. Also, in large hernias, the vas deferens can be displaced, so careful identification is key.
Okay, back to recurrence. What causes it and how is it managed?
Inguinal hernia recurrence can happen due to technical factors, like excessive tension in tissue repairs, missed hernias initially, inadequate mesh overlap, improper mesh placement, or patient factors like chronically elevated intra-abdominal pressure from coughing or straining, deep incisional infections, maybe even poor collagen formation. Recurrences are more common after direct hernia repairs, often occurring near the pubic tubercle where suture line tension is highest in tissue repairs. When investigating a recurrence, it's crucial to always check for a missed or new femoral hernia, as they account for 5–10% of recurrent groin bulges.
How are recurrent hernias fixed?
Management of recurrent hernias almost always requires prosthetic mesh. A different surgical approach is usually preferred, for example, a posterior or laparoscopic approach if the first repair was anterior open. This avoids dense scar tissue, improves visualization of the true defect, and decreases complications like ischemic orchitis and nerve injury. If the recurrence happens after initial mesh repair, it's often due to displaced or inadequate mesh. This is best managed by placing a second prosthesis, again, ideally via a different approach. Meta-analyses show mesh reduces re-recurrence significantly, with no clear difference between laparoscopic and open mesh repairs for recurrence. Re-recurrence rates are around 4 to 5% at 2 years, maybe 7.5% at 5 years. Tension-free mesh-based repairs have the lowest reoperation rates. Unfortunately, the time to recurrence tends to decrease with each subsequent repair, and re-recurrent hernia repairs have longer operative times and greater complication risks. Hashtag quality of life.
Beyond clinical outcomes like recurrence and complications, two major quality indicators are often assessed for hernia repair, reflecting the patient's perspective on recovery: postoperative pain and the time it takes to return to work and normal activities.
Studies consistently show that tension-free and laparoscopic mesh-based approaches are significantly less painful in the postoperative period compared to older non-mesh repairs. Laparoscopic repairs, in particular, tend to be associated with the least amount of postoperative pain and have also been shown to provide a marginal but potentially significant advantage in reducing the time patients need to take off work, allowing for a quicker return to their daily routines.
Now let's take a closer look at femoral hernias, which, while less common than inguinal hernias, carry that higher risk of serious complications. To reiterate our earlier definition, a femoral hernia occurs through the femoral canal, that narrow opening bounded superiorly by the iliopubic tract, inferiorly by Cooper ligament, laterally by the femoral vein, and medially by the lacunar ligament.
Right. A femoral hernia typically presents as a mass or bulge located below the inguinal ligament, distinguishing it from most inguinal hernias which are above it. Sometimes the bulge can ascend over the inguinal canal, but the exit point is still inferior. And as we mentioned, about 50% of men with a femoral hernia have an associated direct inguinal hernia, though only about 2% of women do.
How are they repaired?
Repair methods include the standard Cooper ligament tissue repair, McVeigh, a preperitoneal approach, or a laparoscopic approach.
The essential elements of repair involve dissecting and reducing the sac contents, then obliterating the defect either by approximating the iliopubic tract to Cooper ligament with sutures, or more commonly now, placing mesh, often a small plug or patch.
But the absolute key point, again, is the high incidence of strangulation in femoral hernias, making repair necessary upon discovery. For incarcerated femoral hernias, the sac contents must be examined meticulously for viability.
And if the bowel looks compromised?
Then the Cooper ligament tissue approach is preferred, as mesh is contraindicated in contamination. Sometimes, carefully dividing the lacunar ligament medially can help reduce the incarcerated contents without injuring the femoral vein.
What about an anterior approach for a non-strangulated femoral hernia?
You can do it. Dissect down below the inguinal ligament, find the space medial to the femoral vein, mobilize and reduce the sac. You might need to divide a small part of the inguinal ligament for exposure. Then insert a small prosthetic plug into the empty space, suturing it carefully to Cooper ligament posteriorly, lacunar ligament medially, and inguinal ligament superiorly. Crucially, no suture fixation laterally near the femoral vein to avoid injury.
And recurrence.
Interestingly, a femoral hernia occurring after an inguinal hernia repair happens about 15 times more often than expected. It's unclear if they were missed initially or developed later. Recurrence after a femoral hernia repair itself is low, maybe 2%, but re-recurrence after repairing a recurrent femoral hernia jumps to about 10%.
To round out our comprehensive deep dive, let's take a fascinating glimpse into some of the less common yet often more complex hernia types and scenarios. These present unique diagnostic and surgical challenges. Hashtag sliding inguinal hernia, revisited.
Right, the sliding inguinal hernia, where an internal organ like the colon or bladder forms part of the sac wall. Usually indirect, but can be femoral or direct. The primary danger, again, is failing to recognize that visceral component before injuring it. Management involves carefully reducing the contents, maybe excising redundant sac carefully, closing the peritoneum over the organ, and then using standard inguinal hernia repair techniques. Hashtag recurrent inguinal hernia.
We touched on this, but repair of recurrent inguinal hernias presents a significant challenge, and unfortunately they have a higher incidence of secondary recurrence.
Correct. Successful repair almost always requires prosthetic mesh, unless the original mesh was infected. When a recurrence happens after an anterior mesh repair, the best strategy is typically a laparoscopic or open posterior approach with a second prosthesis. The rationale, again, is avoiding the scar tissue from the prior operation, improving visualization, and reducing complications like ischemic orchitis or nerve injury. Hashtag strangulated inguinal hernia.
We've mentioned the urgency. What's the preferred surgical approach when a strangulated inguinal hernia is suspected?
The source material suggests a preperitoneal approach is often preferred. It offers direct visualization of the sac contents to assess viability, allows precise incision of the constricting ring with minimal danger, and if bowel resection is needed, the peritoneum can be opened easily from that space without needing a second big incision. #tag bilateral inguinal hernias.
What about patients with hernias on both sides?
For bilateral inguinal hernias, the approach depends on the extent. Research indicates that simultaneous repair has similar recurrence rates to unilateral repair, whether done open or laparoscopically. Preferred methods for doing both sides at once often include the giant prosthetic reinforcement of the visceral sac, stopper repair, via an open posterior approach, or a laparoscopic repair, TAP or TAPP, which naturally accesses both sides.
Okay, let's shift our focus now from the groin to the front of the abdomen and explore ventral hernias. By definition, a ventral hernia is simply a protrusion of an organ or tissue through the anterior abdominal wall.
Exactly. And ventral hernias can be categorized broadly as either spontaneous, like epigastric hernias between chest bone and belly button, umbilical hernias at the belly button, or rare hypogastric hernias below the belly button midline. Or they can be acquired, which typically develop after previous surgical incisions and are therefore termed incisional hernias.
It's important to differentiate these from diastasis recti, right?
Very important. Diastasis recti is not a true hernia. It's a stretching and thinning of the linea alba, that midline tissue, causing the rectus muscles to bulge outwards when straining, but there's no actual fascial defect or hernia sac. Surgical correction is generally avoided unless it's significantly symptomatic or part of a larger reconstruction. #tag incidence and risk factors. The incidence of ventral hernias is quite substantial. Incisional hernias alone account for 15 to 20% of all abdominal wall hernias, with umbilical and epigastric hernias collectively constituting about 10%. Annually, an estimated 350,000 to 500,000 ventral hernia repairs are performed in the U.S. alone, underscoring their prevalence. Incisional hernias are about twice as common in women.
What factors are linked to incisional hernias developing after surgery?
Several factors, both technical and patient-related. While the specific type of suture used at the primary operation doesn't have conclusive evidence affecting formation, the surgical technique during closure is highly associated. Using a suture-to-wound length ratio of at least 4.1 with small bites significantly reduces hernia formation compared to larger bites. Patient-related factors include obesity, older age, male gender, sleep apnea, emphysema, prostatism, basically anything increasing intra-abdominal pressure or impairing healing. And wound infection has been definitively linked to hernia formation. Is there controversy about which initial incision type is best, midline versus transverse? There has been. Midline incisions have a reported hernia incidence of 320%, doubling with infection. Some meta-analyses suggest lower rates with transverse or paramedian incisions. However, more recent large analyses suggest similar rates for transverse and midline incisions. Current thinking is that surgeons should plan the incision based primarily on achieving the best operative exposure needed for the procedure, rather than solely on potential hernia risk. #natural history.
Now, when it comes to the natural history of untreated ventral hernias, what happens if they're left alone? There are surprisingly few data available. Unlike inguinal hernias, where watchful waiting is an option for some, it's currently unclear if this paradigm applies effectively to asymptomatic ventral or incisional hernias.
Right. Since there isn't definitive data to determine the natural history or long-term risks reliably, most surgeons currently recommend that these hernias be repaired once they're discovered, rather than observing them, reflecting a more proactive approach given the potential for progression and complications like enlargement or incarceration. #anatomy of the anterior abdominal wall.
Understanding the anatomy of the anterior abdominal wall is vital for appreciating how ventral hernias occur and how they're repaired. Compared to the intricate groin anatomy, the anterior abdominal wall is often described as relatively straightforward, yet a clear understanding of its layers and blood supply is absolutely critical, especially when performing advanced abdominal wall reconstruction.
That's right. It's simpler in some ways, but still has key features. The anterior abdominal wall is essentially a strong envelope formed by three layered lateral muscles: the external oblique, superficial, internal oblique middle, and transversus abdominis, deepest. The flat tendons, or ponderoses, of these muscles meet in the midline to form the linea alba. On either side of the linea alba are the paired longitudinal rectus abdominis muscles.
And the arcuate line. That sounds important.
It is. The arcuate line is a key landmark, typically 3 to 6 centimeters below the umbilicus. It signifies a point of potential weakness. Above the arcuate line, the posterior side of the rectus muscle is strongly supported by fascia from the internal oblique and transversus abdominis. But below the arcuate line, those fascial layers pass anterior to the rectus muscle, leaving the posterior rectus sheath significantly thinner, composed mainly of just transversalis fascia and peritoneum. This makes the lower midline potentially weaker.
Okay, so less support down low. What about nerves and blood supply?
The wall is innervated by lower intercostal nerves and upper lumbar nerves, which run between the internal oblique and transversus abdominis. Blood supply comes from the superior and inferior epigastric arteries running behind the rectus, and lower intercostal arteries. A critical point for surgeons doing reconstruction is preserving the tiny periumbilical perforator vessels. These small vessels supply blood to the overlying skin near the belly button. Sacrificing them during undermining can lead to skin flap necrosis, highlighting the precision required. #diagnosis of ventral hernias.
For the diagnosis of ventral hernias, a diligent physical examination remains paramount, just as with inguinal hernias. The anterior abdominal wall is meticulously evaluated with the patient in both standing and supine positions, and the Valsalva maneuver is again useful to help demonstrate the site and size of the hernia.
Exactly. While physical exam is the cornerstone, imaging modalities play a greater role in diagnosing more unusual or complex ventral hernias, especially incisional hernias, or when loss of abdominal domain is suspected where the contents won't easily fit back in. Computed tomography, CT evaluation, and surgeon-performed ultrasound, sometimes called DASH, dynamic abdominal sonography for hernia, are cited as the most useful adjuncts for clarifying anatomy, defect size, and contents. Hashtag classification of ventral hernias. Hashtag umbilical hernia.
Let's break down the types. First, the umbilical hernia, occurring right at the umbilicus, the belly button.
Right. In infants, umbilical hernias are congenital, very common, and often close spontaneously by age 2. Surgery is usually only needed if they persist past age 5. There's a strong predisposition in individuals of African descent. In adults, they're largely acquired, more common in women and those with increased intra-abdominal pressure from things like pregnancy, obesity, or ascites, fluid in the abdomen. Complications like strangulation are unusual, but rupture can occur in severe ascites, which is dangerous.
How are adult umbilical hernias managed?
Small asymptomatic adult hernias may not need repair. However, adults with symptoms, a large hernia, incarceration, thinning overlying skin, or uncontrollable ascites should generally have repair. Historically, the Mayo vest over pants tissue repair had high recurrence rates, around 30%, and is rarely done today. For small defects, usually less than 3 centimeters, primary suture closure is performed after separating the sac. For larger defects, greater than 3 centimeters, prosthetic mesh is typically used. There's no clear advantage of one mesh technique over another here. Options include bridging the gap, placing mesh as a peritoneal underlay, or even laparoscopic placement. No universal consensus yet. Hashtag epigastric hernia.
Next, let's discuss epigastric hernias. These are found in 3% to 5% of the population, 2 to 3 times more common in men, and located in the midline between the xiphoid process, bottom of the sternum, and the umbilicus.
Yes, they often occur where there's a single aponeurotic decussation, a natural weak spot. These defects are often small, but can cause disproportionate pain, frequently from incarcerated peritoneal fat getting pinched. Up to 20% of patients have multiple epigastric hernias, and 80% are midline.
How are these repaired?
Repair typically involves excising the incarcerated fatty tissue and simple closure of the small fascial defect, similar to small umbilical hernias, often done under local anesthesia. For sizable defects, or those containing omentum or bowel, mesh reinforcement might be needed. They are generally better repaired anteriorly because the defect is small, and reducing the fat from a deep approach can be difficult. Hashtag incisional hernia.
Of all the hernias we've discussed so far, incisional hernias are consistently cited as the most challenging and difficult to treat. These hernias occur as a direct result of excessive tension and inadequate healing of a previous surgical incision, often compounded by a surgical site infection. Over time, these hernias tend to enlarge, leading to pain, bowel obstruction, incarceration, and even strangulation.
Exactly. Predisposing factors include obesity, advanced age, malnutrition, ascites, pregnancy, conditions causing increased intra-abdominal pressure, like chronic lung disease or diabetes, medications like corticosteroids or chemo, and definitely surgical site infections contributing to poor wound healing.
And you mentioned loss of abdominal domain.
Yes, a significant concern with large or long-standing incisional hernias is the potential for loss of abdominal domain. This occurs when the herniated abdominal contents have resided outside the abdominal cavity for so long that they effectively no longer fit back inside the original abdominal space without causing problems. This compromises the natural rigidity and function of the abdominal wall. Muscles retract laterally, and it can lead to respiratory dysfunction, bowel edema, urinary retention, constipation. Attempting to return the viscera during repair can significantly increase intra-abdominal pressure, potentially causing abdominal compartment syndrome and acute respiratory failure. It requires careful planning. #tag ventral incisional hernia classification systems.
Given the immense complexity of ventral incisional hernias, considering defect size, location, loss of domain, patient comorbidities, contamination, prior repairs, presence of ostomies, there's been a lack of a simple, universally accepted mechanism for effectively communicating this complexity and predicting outcomes.
Right. That lack of a common language hinders comparison of results between different techniques and centers. Recognizing this gap, experts have developed classification tools. The goal is really to predict surgical outcomes, particularly surgical site occurrences, SSO, like infection or seroma, and long-term recurrence rates using preoperative variables.
What are some of the systems used?
Well, the Ventral Hernia Working Group, VHWG grading scale, uses patient comorbidities like obesity, smoking, diabetes, and the wound class, clean, contaminated, etc., to predict SSO risk. The European Hernia Society, EHS system, primarily assesses hernia width and location.
Have these been validated?
They're useful, but recent data from a multivariate analysis of over 300 repairs suggested something interesting. Hernia width, categorized as 10 centimeters, 20 centimeters, or 20 centimeters, and the presence of contamination were the two most significant variables associated with both wound morbidity, SSO, and hernia recurrence. In that specific model, location and comorbidities were not found to be independently significant predictors.
So width and contamination were key.
In that analysis, yes. This has led to the development of the incisional hernia staging system. It's quite simple. Stage 1, defect 10 centimeters wide, clean wound, low risk, 10% SSO, 10% recurrence. Stage 2, either 10 centimeters contaminated or 20 centimeters clean. Moderate risk, 20% SSO, 15% recurrence. Stage 3, either 10 centimeters contaminated or any defect 20 centimeters wide, regardless of contamination. High risk, 42% SSO, 26% recurrence.
That seems pretty clear and practical for risk stratification.
Exactly. It's simple and comprehensive for stratifying risk based on those two key factors. It's important to note, though, that the system doesn't include intraoperative details like the surgical approach, mesh choice, or mesh position, but it provides a good platform for standardizing reporting and designing future studies.
Now let's turn to the operative repair of ventral hernias. It's generally agreed among surgeons that all but the very smallest incisional hernias, typically those less than or equal to 2 to 3 centimeters in diameter, will require repair with prosthetic mesh.
Right. Primary repair, meaning simply closing the fascial defect with sutures without mesh, might be possible for those very small defects with good quality surrounding tissue, or maybe if there was a clear technical error in the original closure.
But for anything bigger.
For larger defects, exceeding 2 to 3 centimeters, primary suture closure alone carries a predictably high recurrence rate, often quoted at 50% or more. This strongly reinforces the idea that incisional hernia is indeed a chronic disease process, meaning a variety of management options, often involving mesh reinforcement, will likely be needed to care for a patient throughout their lifetime. #tag prosthetic materials for ventral hernia repair.
Okay, let's do a deeper dive into the prosthetic materials themselves, the meshes that are so central to modern ventral hernia repair. Surgeons have various options for placing the mesh: onlay, over the fascia, interposed, bridging the gap, sandwiched, or sublay, underneath the fascia. When choosing, they must consider the mesh position, whether it will have direct contact with abdominal viscera, and the inherent risk of infection.
Exactly. It's a complex decision.
Yeah.
Let's start with permanent synthetic materials. The ideal mesh hasn't really been defined, but desirable characteristics include being chemically inert, resistant to mechanical stress while maintaining compliance, sterilizable, non-carcinogenic, causing minimal inflammation, and hypoallergenic.
What are the main types?
Polypropylene is workhorse. It's hydrophobic, macroporous, meaning it has large pores allowing fibroblast ingrowth for tissue integration, semi-rigid but flexible. It comes in different weights, classified somewhat arbitrarily: lightweight, 40 geometer days, medium, intermediate, heavyweight, 75 geometer dozens. Lightweight often has an absorbable component for initial stability.
Is lightweight better than heavyweight?
That's a huge area of controversy with mixed results.
Yeah.
For inguinal repair, one trial showed heavyweight had less recurrence pain laparoscopically, but a large registry found lightweight had fewer mesh-related issues long-term in open repair, so lightweight is often favored there now, unless it has absorbable components. For ventral hernia repair, though, one study showed lightweight polypropylene had twice the recurrence rate, 17% approaching significance. There are also some concerns about central mesh failures with ultra-lightweight meshes in ventral repairs. So the jury's still out, and it might depend on the location and technique.
What about infection?
Large pore lightweight mesh may resist bacterial contamination. Better animal studies show high bacterial clearance. A retrospective series using large pore polypropylene in contaminated ventral repairs showed a promising 7% recurrence rate medium term, but longer data is needed.
Other synthetics.
Polyester, like Dacron, is hydrophilic, heavyweight, macroporous. Different weaves exist. Seems comparable in peritoneal placement for complex ventral hernias, but long-term infection data is needed. Expanded polytetrafluoroethylene, EPTFE, like Gore-Tex, is often used for intraperitoneal placement because it's smoother and theoretically causes fewer adhesions. It can be single sheet or composite, one side for ingrowth, one for adhesion resistance. It's microporous on the visceral side, flexible, smooth, but it doesn't really incorporate into native tissue. It gets encapsulated. A critical downside, if EPTFE gets infected, it almost always must be removed, resulting in another large defect.
So infection is a major problem for EPTFE. What about composites?
Composite mesh often combines polypropylene for tissue ingrowth facing the fascia and EPTFE facing the bowel. A potential issue is variable contraction between the layers, which can cause buckling and expose the bowel to the polypropylene side. Other composites use macrorose mesh with a temporary absorbable anti-adhesive barrier, like oxidized cellulose, omega-3 fatty acids, collagen hydrogels. Animal studies validate the anti-adhesive properties, but we lack human trial data comparing them long-term.
Okay, shifting from synthetic to biologic.
Right, biologic materials. These are non-synthetic natural tissue meshes derived from human dermis, porcine dermis or intestine, or bovine pericardium, for example. They're processed to remove cells, leaving in cellular collagen scaffold. Processing varies cross-link versus non-cross-link, different sterilization methods. The idea is this matrix allows for neovascularization and deposition of the patient's own native collagen, essentially remodeling into host tissue.
What are the advantages?
Their main potential advantage is in infected or contaminated fields, where placing permanent synthetic mesh is contraindicated due to the high risk of chronic infection and mesh removal. They might offer a way to reconstruct in those challenging situations. Ideally, their best use is fascial reinforcement rather than bridging a gap.
But are they durable?
That's the big question. Long-term durability, especially in the largest series evaluating them in contaminated settings, has been questioned, with high recurrence rates reported. Their current use is mainly in challenging contaminated situations where permanent mesh is ill-advised and native tissue closure is difficult or impossible. They can act as a temporary bridge to prevent evisceration. But importantly, there's no prospective randomized data directly comparing their effectiveness against synthetic mesh in clean or contaminated wounds.
What about absorbable synthetics?
Absorbable synthetic materials are gaining popularity as an alternative. Polygalactin, like Vicryl mesh, has been a mainstay for contaminated fields. It can be placed anywhere, ideally with soft tissue coverage, but absorbs rapidly via hydrolysis in 8 to 9 weeks. Variations exist with slower hydrolysis. One prospective series using slowly resorbable polygalactin in the retromuscular space for contaminated complex ventral hernias showed a 17% recurrence rate. Poly-4-hydroxybutyrate, P4HB, is promising, showing only 9% recurrence at 18 months in clean wounds. It resorbs completely over 12-18 months. However, bare P4HB mesh is not placed intraperitoneally. A word of caution. Some longer-term absorbable heavyweight meshes should be avoided in contaminated situations, as studies showed they had increased 30-day infections compared to mid-weight polypropylene.
Now that we've delved into the various mesh materials, let's explore how they are actually placed during ventral hernia repair. It's generally agreed that all but the smallest incisional hernias will be repaired with mesh, and surgeons have various options for placing that mesh, each with its own advantages and disadvantages.
Absolutely. Let's look at the main placement strategies. The onlay technique involves primary closure of the fascial defect, if possible, and then placing the mesh over the repaired anterior fascia under the skin and fat. Advantages are that the mesh is outside the abdominal cavity, avoiding direct interaction with the bowel. Disadvantages include needing large subcutaneous flaps, which increases the risk of seroma, fluid collection formation. Also, the superficial mesh is at risk of contamination if the skin incision gets infected, and the repair is often under some tension. Recurrence rates in retrospective reviews have been around 28%, though some modifications show better results.
What about placing it right in the defect, edge to edge?
That's the interposition prosthetic repair, sometimes called inlay or bridging. Mesh is secured just to the fascial edge without overlap. This predictably has high recurrence rates because intra-abdominal pressure tends to pull the synthetic mesh away from the fascial edge over time, generally avoided for durable repairs.
So underlay or sublay seems better.
The sublay technique is widely considered highly desirable for ventral hernia repair. It involves placing the prosthetic mesh below the fascial components of the abdominal wall. This could be intraperitoneally inside the abdomen, preperitoneally just outside the peritoneum, or retrorectus behind the rectus muscles. This approach is advantageous because it allows for wide mesh overlap beyond the defect edges, and it utilizes natural abdominal forces, Pascal's principle, to hold the mesh in place, theoretically preventing migration and reducing recurrence.
How is intraperitoneal mesh placed?
Intraperitoneal mesh placement usually involves reopening the prior incision, lysing adhesions between the bowel and the abdominal wall, and then placing a dual type or a composite mesh inside the abdomen. The mesh needs to extend at least 4 centimeters beyond the fascial margin in all directions, and is secured circumferentially, often with interrupted mattress sutures passed through the full thickness of the abdominal wall. This requires raising subcutaneous flaps and puts the mesh in direct contact with abdominal contents, necessitating a barrier-coated mesh.
And the laparoscopic approach?
The laparoscopic approach for ventral hernia repair, often called IPO intraperitoneal onlay mesh, relies on similar principles to sublay repair, but the mesh is placed within the peritoneal cavity using minimally invasive techniques. It's particularly useful for patients at high risk for wound complications because it avoids large incisions and extensive subcutaneous undermining. The technique involves placing trocars laterally, reducing the hernia contents, carefully lysing adhesions laparoscopically. The defect is measured, and a suitable barrier-coated mesh is chosen, again needing at least 4 centimeters overlap. The mesh is rolled, inserted through a port, deployed inside, and secured. Fixation often involves transfascial sutures, passed through small skin incisions, combined with tacks or staples placed circumferentially onto the abdominal wall from the inside. For smaller defects, some surgeons might close the defect primarily with sutures before placing the mesh over. Fewer wound issues seem like a big plus there. Definitely a major advantage of the laparoscopic IPO approach.
Beyond just placing mesh, one of the fundamental underlying principles of truly advanced abdominal wall reconstruction, especially for larger or complex hernias, is the critical need to reestablish the linea alba. Restoring this central tendinous structure to the midline aims to create a more functional abdominal wall, protect the underlying mesh, and hopefully result in a more durable, long-lasting repair.
Exactly. To achieve this, particularly when the fascial edges are far apart, surgeons utilize myofascial release techniques. This involves surgically separating a fascial layer from an underlying muscular layer. In larger hernias, these releases allow the rectus muscles to be advanced medially towards the midline, essentially creating local advancement flaps out of the patient's own abdominal wall tissues. The basic tenets rely on understanding the myofascial compartments of the abdominal wall. Releasing one or more layers allows the rectus complex to move. A critical aspect is preserving the neurovascular structures supplying the rectus muscles to ensure they remain functional and well vascularized.
What are the main release techniques?
One foundational technique, often combined with mesh placement, is the posterior rectus sheath incision with retromuscular mesh placement, often credited to Stoppa or Rives. Here, mesh is placed in the extraperitoneal retrorectus space that's behind the rectus muscles, but in front of the posterior rectus sheath above the arcuate line, or peritoneum below it. Access is gained by incising the posterior rectus sheath near the medial edge of the rectus muscle. Dissection creates a space laterally behind the muscle. The posterior sheath leaflets, or peritoneum, are then sutured together in the midline, creating an extraperitoneal pocket. A large piece of mesh is placed in this pocket, extending well beyond the defect borders. Fixation might involve transfascial sutures, though for smaller defects it might not be needed due to Pascal's principle holding it. For larger defects, it's often secured laterally. A major advantage is avoiding MAC-bowel contact. Outcomes show good durability, maybe 14% recurrence long-term for large hernias.
What if even more advancement is needed?
For larger hernias, or where the rectus muscles are atrophied and retracted, a posterior component separation, often called transversus abdominis release, TAR, can provide adequate mesh overlap and allow posterior sheath closure. This involves further lateral dissection. After incising the posterior rectus sheath, the transversus abdominis muscle itself is divided vertically, just medial to where the nerves enter the rectus sheath. This gains access to the pretransversalis, or preperitoneal space. Dissection extends laterally into the retroperitoneum, potentially reaching the psoas muscle. This allows placement of very large mesh sheets with wide defect coverage and significant medial advancement of the rectus complex. Outcomes show similar fascial advancement to anterior component separation, but with a significant reduction in wound morbidity compared to the anterior approach. It offers excellent durability with acceptable short-term morbidity in expert hands.
What about releasing from the front, the anterior component separation?
Yes, the anterior component separation involves separating the lateral muscle layers from the front to allow advancement, often enabling primary fascial closure at the midline, even for large defects. The technique usually involves raising large subcutaneous flaps above the external oblique fascia, laterally past the edge of the rectus muscle, linea semilunaris. Preserving large perforating subcutaneous blood vessels is critical here to prevent ischemic skin necrosis. A relaxing incision is then made vertically on the external oblique aponeurosis, about 2 cm lateral to the linea semilunaris, from the costal margin down towards the pubis. The external oblique is bluntly separated from the underlying internal oblique in a vascular plane, allowing medial advancement. Further release can be obtained by incising deeper layers, but that can result in problematic lateral bulges or herniation. Additional release can come from incising the posterior rectus sheath too. Done bilaterally, this can yield up to 20 centimeters of mobilization.
What are the outcomes like?
It allows tension-free closure, which is good, but recurrence rates can still be as low as 20%, even with prosthetic reinforcement in large hernias. Patients also need to understand the potential for a lateral bulge where the external oblique was cut. Using biologic mesh reinforcement with this technique hasn't shown lower recurrence in RCTs compared to synthetic mesh. ## robotic approaches to ventral hernia repair. Revisited.
Building on our discussion of robotic techniques for inguinal hernias, it's worth noting that robotic surgery can also be effectively used to perform several different types of ventral hernia repairs, ranging from relatively straightforward intraperitoneal mesh placement to highly complex retromuscular repairs with posterior component separation.
Absolutely. Robotics offers potential advantages here too. For robotic intraperitoneal mesh placement, IPOM, the steps are similar to standard laparoscopic IPM. Ports are placed laterally, adhesions lysed, hernia reduced. A key difference is the ability to potentially close the hernia defect, primarily with continuous barbed suture robotically before placing the mesh. The tissue separating mesh is then chosen with 4 or 5 centimeter overlap, introduced and fixated circumferentially, often using continuous barbed suture techniques like a baseball or dolphin stitch, rather than relying solely on tacks. This might reduce pain associated with tack fixation. A large registry study comparing robotic IPM versus laparoscopic IPM found robotic had longer operative times but significantly shorter length of stay, median 0 versus 1 day, and a lower surgical site occurrence, SSO rate, 5% is 14%.
What about the more complex robotic repairs, like retromuscular or TAR?
Yes, robotic retromuscular repair with TAR is becoming increasingly adopted. Patient selection is critical. It's particularly well suited for patients with risk factors for wound morbidity, smoking, diabetes, obesity, where avoiding a large open incision is beneficial. Advantages are that it replicates the steps of the open rive stapa or TAR repair, but with the decreased wound complications expected from a minimally invasive approach. Studies show shorter hospital stays compared to open TAR, with no difference in 30-day readmissions, although maybe an increased rate of seromas SSOs. It seems best suited for midline defects up to maybe 15-20 centimeters wide, allowing good cosmetic results.
Can you briefly outline the robotic TAR technique? It sounds complex.
It is quite involved, requiring significant robotic skill. Essentially, 1. Place the robotic ports laterally on one side. 2. Incise the contralateral posterior rectus sheath vertically. 3. Dissect the retrorectus space widely. 4. Peel the posterior sheath off the rectus muscle. 5. Dissect laterally to the neurovascular bundles. 6. Incise the posterior rectus sheath and transversus abdominis muscle just medial to the nerves, entering the pretransversalis plane. 7. Dissect this deeper plane laterally, peeling peritoneum transversalis fascia off the cut transversus abdominis. 8. Repeat the entire retrorectus star dissection identically on the contralateral side. Requires repositioning the robot. 9. Suture the posterior rectus sheaths together in the midline robotically, closing the visceral sac. 10. Suture the anterior rectus sheath hernia defect together in the midline. Reducing intra-abdominal pressure helps. 11. Deploy a large, standard, flat synthetic mesh like polypropylene into the huge retromuscular pocket. It's typically not fixated as it conforms to the space. 12. Remove ports. Fascial closure often not needed for port sites because the mesh extends beyond them.
Wow, that's intricate. What about robotic TEP for ventral?
Yes, the robotic extended TEP technique for ventral incisional hernias. This aims to replicate the posterior rectus sheath incision with retromuscular mesh placement, but avoids entering the abdominal cavity at all, potentially allowing same-day surgery and avoiding adhesiolysis. Patient selection is crucial. Works best for patients with wide rectus muscles and hernia defects, maybe 10 to 12 centimeters. Preoperative CT helps plan access. The technique involves entering the retrorectus space directly on one side, insufflating it, dividing the posterior rectus sheath insertion along the linea alba, dissecting across the midline in the preperitoneal plane, entering the contralateral retrorectus space by incising its posterior sheath from behind, reducing the hernia sac, often intact, repairing the defect, and placing mesh in the combined retrorectus preperitoneal space, all without entering the main peritoneal cavity. TAR can be added if needed. Again, the mesh is typically not fixated. Hashtag results of incisional hernia repairs.
Now, let's examine the results of incisional hernia repairs comparing different approaches. Several prospective randomized trials have compared laparoscopic and open ventral hernia repairs. While most of these studies have been relatively small, their results generally tend to favor a laparoscopic approach for small to medium-sized defects, primarily due to fewer postoperative complications and potentially a lower incidence of recurrence.
Indeed, several retrospective reports have also demonstrated similar advantages for a laparoscopic approach in ventral hernia repair, particularly regarding wound complications. However, it's important to acknowledge that until appropriately powered prospective randomized trials comparing modern open techniques, like TAR, with laparoscopic and robotic approaches for different hernia sizes and complexities are performed, the ideal approach for any given ventral hernia will largely be based on the individual surgeon's expertise, patient factors, and preference. Future trials are definitely needed to guide selection.
To round out our comprehensive deep dive, let's take a fascinating glimpse into some of the less common, yet equally complex, hernia types. These present unique diagnostic and surgical challenges that really test a surgeon's knowledge.
Absolutely. Beyond the common inguinal and ventral hernias, there are several unusual hernias that surgeons may encounter, requiring specialized understanding.
Like the Spigelian hernia.
First, the Spigelian hernia. This hernia occurs through a specific fascial layer called the Spigelian fascia, located between the rectus muscle medially and the semilunar line laterally. Almost all occur at or below the arcuate line where the posterior sheath is absent. They're often interparietal, meaning the sac dissects posterior to the intact external obliquoponderosus. Because of this, patients often have localized pain but no visible bulge, making diagnosis challenging. Ultrasound, or CT, perhaps dynamic ultrasound, DASH, is crucial. These hernias have a high risk of incarceration due to their typically narrow neck necessitating repair, often open with simple closure or mesh, though laparoscopic is possible.
What about the obturator hernia?
Next, the obturator hernia. This hernia occurs through the obturator canal in the pelvis, a small opening where the obturator nerve and vessels pass. Weakening allows herniation. It's dangerous due to high risk of intestinal incarceration strangulation. A classic symptom, though not always present, is pain in the anteromedial thigh radiating to the knee, Hauschip-Romberg sign, due to nerve compression, often relieved by thigh flexion, almost half present with bowel obstruction. Diagnosis is usually via abdominal CT. Repair is preferably via a posterior approach, open or laparoscopic, using prosthetic mesh, carefully avoiding the nerve and vessels.
Lumbar hernias. In the back.
Lumbar hernias occur in the lumbar region of the posterior abdominal wall, either congenitally or acquired after flank surgery or trauma. They occur through weak spots. The superior lumbar triangle, Grinfeld more common, or the inferior lumbar triangle, Pidet less common. They involve weakness of the lumbodorsal fascia. While they can cause back pain, they are generally not prone to incarceration. Repair is best done with prosthetic mesh sutured beyond the margins. The suture repair is difficult due to immobile bone margins.
Sciatic and perineal hernias sound very rare.
Extremely rare. Sciatic hernia protrudes through the greater sciatic foramen in the buttock, often asymptomatic until bowel obstruction, or may present as a gluteal mass or sciatic nerve pain. Repair is usually transabdominal, preferably with mesh. Perineal hernia protrudes through the pelvic diaphragm, often after pelvic surgeries like abdominoperineal resection, presents as a bulge worsened by sitting standing. Repair is transabdominal or combined, often needing mesh for larger defects.
And revisiting loss of domain.
Loss of domain hernias, as we discussed with incisional hernias, represent that challenging category. A massive hernia where contents have resided outside the abdomen so long they can't simply be replaced without causing excessive pressure. Preoperative evaluation and optimization, weight loss, smoking cessation, nutrition, glucose control are crucial. Techniques to restore domain might include progressive pneumoperitoneum, gradual air insufflation over weeks to stretch the abdomen, or complex staged repairs, sometimes involving initial large mesh placement followed by serial excision until fascia can be closed, potentially with component separation and biologic mesh. These are major undertakings with high morbidity.
Lastly, parastomal hernias around stomas.
Finally, the parastomal hernia, occurring around a surgically created stoma, like a colostomy or ileostomy. It's a very common complication, seen in up to 50% of colostomies. Often, asymptomatic life-threatening complications are rare. Because of this, and the fact that repairs have high recurrence and complication rates, routine repair of asymptomatic parastomal hernias is not generally recommended, unlike midline incisional hernias. Repair is usually reserved for significant symptoms like bowel obstruction, inability to maintain a pouch seal, or major cosmetic issues.
What are the repair approaches?
3 general approaches. 1. Primary fascial repair. Reducing the hernia and suturing the fascia closed around the stoma. Predictably high recurrence rate, but avoids entering the abdomen, maybe for frail patients. 2. Stoma relocation. Moving the stoma to a new site. Requires laparotomy and unfortunately predisposes to another parastomal hernia at the new site. 3. Prosthetic repair. Using mesh offers better long-term results and lower recurrence, but carries a higher rate of potentially serious prosthetic complications. Having a permanent foreign body right next to the bowel loop risks erosion, obstruction, fistula formation, potentially disastrous outcomes. Mesh can be placed as an onlay, intraperitoneally, often with a keyhole cut around the stoma, or lateralizing the stoma sugar baker technique, or in the retrorectus position. Newer retromuscular repairs involving stoma relocation and large mesh placement are being explored but lack long-term data. 3. Prosthetic repair. Hashtag check general complications of hernia repair, beyond inguinal specifics.
As more and more patients undergo hernia repair, especially with the widespread use of mesh over the last few decades, there's naturally been a heightened focus on potential mesh-related complications. It's a growing area of concern as a larger population lives with long-term indwelling mesh.
Absolutely. The rate of these potentially harmful mesh-related complications isn't as well characterized as we'd like, partly due to surveillance limitations. For instance, a Danish population study found that 4.9% of patients required operative mesh removal within 5 years of ventral hernia repair. This highlights a significant challenge. The lack of an effective post-market surveillance system, particularly in the U.S., makes it difficult to truly determine the rate and nature of serious long-term mesh complications across different mesh types and procedures.
One of the most feared is mesh infection.
Yes, mesh infection is serious and difficult to treat. Management depends on the severity. Acute infection with sepsis requires urgent, aggressive treatment. Hospital admission, IV antibiotics, early surgical debridement, and often complete mesh removal. Chronic, indolent infection without sepsis might allow for mesh salvage attempts. This could involve percutaneous drainage of fluid collections, long-term antibiotic suppression based on cultures, and careful monitoring. Success depends on patient factors, controlling diabetes, eliminating nicotine, weight loss, and the type of prosthetic.
Does the mesh type matter for infection salvage?
Yes. EPTFE mesh, if infected, almost always requires removal because bacteria colonize its microporous structure and it doesn't integrate well. This results in another defect, often closed under tension, leading to inevitable recurrence. Polyester often requires at least partial removal, though well-incorporated areas might sometimes be left, considering the morbidity of complete removal. Polypropylene, especially macroporous types, offers the best chance for mesh salvage with conservative measures because tissue ingrowth can help control infection.
Does the surgical approach affect infection risk?
For ventral hernias, laparoscopic approaches generally have a significant reduction in infectious complications, often less than 1% in large series, compared to open repairs, mainly due to smaller incisions and less tissue dissection. However, minimally invasive approaches carry a slightly higher risk of missed enterotomy, bowel injury, during adhesiolysis.
What about seromas, fluid collections?
Seromas are common after both laparoscopic and open ventral hernia repair. With open repairs, drains are often placed to obliterate the dead space created by flap elevation, but seromas can still form after drain removal. With laparoscopic repairs, the hernia sac isn't usually resected, leaving a potential space where seroma fluid collects. Most resolve spontaneously over weeks to months as the mesh incorporates. Management involves preoperative discussion with the patient about this likelihood. Aspiration is generally reserved only for symptomatic, painful, tense, or very persistent seromas after 6 to 8 weeks, as aspiration carries a small risk of introducing infection.
And lastly, that risk of bowel injury, enterotomy.
Enterotomy, or intestinal injury,
usually occurring during adhesiolysis, taking down scar tissue, can be a catastrophic complication, especially if missed intraoperatively. Management, if an enterotomy is recognized during repair, is controversial. It depends on the segment injured, small versus large bowel, and the degree of spillage or contamination. Options might include aborting the hernia repair entirely, proceeding with a primary tissue repair or using a biologic tissue mesh instead of synthetic, or potentially performing a delayed repair with prosthetic mesh after a few days once the bowel has healed and contamination risk is lower. The crucial point is, if there is gross contamination from bowel contents, placing permanent synthetic mesh is absolutely contraindicated due to the unacceptably high risk of severe, potentially life-threatening infection.
Wow, what an incredible journey we've just taken. We've truly unpacked the sheer breadth and depth of knowledge surrounding hernias, moving from their basic definition and intricate anatomical pathways all the way to the cutting edge of robotic surgery and the nuanced world of various mesh materials and the complex management of complications. It's clear that understanding this field like an elite professional involves appreciating not just the facts, but the interconnectedness of anatomy, surgical technique, and patient outcomes, and really recognizing the chronic nature of this condition.
Indeed. This deep dive truly highlights the chronic nature of hernias, underscoring that it's often a condition affecting patients over their lifetime, rather than just a one-time fix needing a simple patch. The evolving understanding of abdominal core health is a testament to the increasingly holistic and multidisciplinary approach required for patient care, emphasizing stability, function, and quality of life, not just closing a hole. This field is incredibly dynamic, with ongoing research continually refining optimal treatments and prevention methods.
Absolutely. So, as we wrap up this deep dive, consider this provocative thought for you, our listener. Given the chronic nature of hernias and the constant evolution of repair techniques, from tissue repairs to tension-free mesh to robotics, how might future advances in regenerative medicine or perhaps personalized collagen therapies further transform hernia prevention and treatment in the coming decades? Could we someday see methods that actually rebuild strong native tissue from within, potentially rendering even today's tension-free mesh-based methods seem, well, almost primitive? Think about how this deep dive into the complexities of hernias might inform your own understanding of chronic health conditions and the relentless, fascinating pursuit of better patient outcomes.